Good morning, everybody. Hope everyone's enjoying this nice, cool Chicago weather. I know that I am. I left Texas, and I think it was probably about 80 degrees or so when I left, and so it was cold, cruel reality when we got off that plane. Well, I thank the Academy for kind of providing us the opportunity to speak to you today. It's about a topic that's near and dear to my heart, and I've wrestled with kind of what to speak to you about today. You know, usually when I talk about the state of practice, I'm talking about components and what's on the horizon. But what I thought today is I want you to go home and I want you to be able to practice upper limb prosthetics better. And I thought, what better way to do it than talk about some of the lessons that I've learned, the mistakes I've made, and the things that I've stumbled upon through practice, refinement of the techniques that I use every day. I want to introduce you to our patient population. The upper limb population is very unique. It differs greatly from the normal patient a general practice would see, and talk to you about some of what's considered axioms, or kind of those fundamentals that I feel are important to enhance your outcomes every day at your practice. Talk about some paradigm shifts that I see in the field. These paradigm shifts go from everywhere from components that are available to even the population that we'll be treating in the next couple years. And then how you apply some of that to your practice, and what I think is some of the most important aspects of that. When I got into school, because I wanted to do upper limb prosthetics, which was sort of unusual for my class. I had come through Scottish Rite, I'd done my volunteering there, I'd hung out on all the upper limb fittings. And this statement, you know, in one of my first upper limb books, never rings so true than it does today, and it rings truer, in fact, every day, is that the hand is this precise and dexterous mechanism, and it really defies the casual understanding, especially as we move into partial hand fittings and the biomechanics that are created by the injury or the surgical reconstruction, and that at the heart of it, an early and thorough evaluation, quickly introducing those patients into prosthetic care, into therapy, is very helpful to their functional outcome. The upper limb population is, as I said earlier, is unique. As you read through some of the literature, you find out that the hand is probably the injury to the hand is the most common reason people go into the emergency room, at least one of them. And we seem to always be putting our hand in harm's way. These patients are typically younger, like this individual on the right who, during a New Year's celebration, had not let go of that firecracker quite quick enough and resulted in a partial hand level amputation. And because of the traumatic nature, the limbs are varied, and the efforts of the surgeon to try to reconstruct that were often given very different residual limbs, very difficult to manage residual limbs. You don't typically have the repeat of the dysvascular below knee amputee, where you kind of develop a pattern or a certain set of criteria that you go through. Almost every patient can be different with very unique things that you need to address. And to kind of illustrate that more, the differences between lower and upper limb, you can recognize by these particular numbers that the traumatic presentation, makes up for about 92% of all upper limb amputees, whereas you would suspect with the lower limb, it's about 78% dysvascular. And you break down those lower limb or those upper limb numbers more, and you see that the vast majority of those amputations distal to the wrist. It's just really a small amount of upper limb amputees with a level proximal to the wrist that are living today. It makes up for kind of a 1 to 12 ratio. And finally, when you think about what a loss to the hand, an injury to the hand actually means, and if you look to the chart on the right, just a loss of the fingers, which in the earlier slide they considered a minor issue, a minor amputation, but something that's a 90% upper extremity impairment probably wouldn't be considered a minor issue. So when people even have a small injury to their hand, what we might consider insignificant, it does have a devastating effect to their functional life. Looking further at some of the numbers, looking at the incidence of upper limb versus lower limb a year, we looked at Dillingham and kind of break his numbers down. And this is where we get the about 18,000 or so upper limb amputations a year versus the 1,000 or 100,000 or so lower limb amputations per year. And when you start to exclude the kind of the finger levels, the thumb levels, this toe, kind of partial foot levels, we come up with this 1 to 30 ratio, where in the normal practice, there might be 30 lower limb patients, in a given year to only 1 upper limb patient in that year. And what that creates is a very difficult challenge for the practice to just gain that knowledge, that expertise that someone needs to effectively treat that individual. Because when it comes right down to it, we learn best by repeating and refining what we do. If there's only 1 patient or 2 patients a year, and sometimes that spread is a lot further, it gets hard to build upon what you learned, because in that time span you might have forgotten what you did. So there's several different authors who will talk about why this disparity actually exists between upper and lower limbs. And we look at it primarily as probably an overall safety type issue, first of all. There's fewer agricultural workers, and the workplace themselves are a lot safer than they ever used to be. And with automotive safety engineering, as a buzzword of outsourced manufacturing, those injuries just are not occurring here. Then you always have to think about the improved surgical and rehabilitation techniques that allow for more replants and reviving of that injured residual limb. And in general, it's thought that the overall incidence of upper limb is probably decreasing, at least probably staying the same. It's not necessarily increasing. And then we often think of, well, why this disparity between upper and lower limb technologies? And I often think that this is probably the nightmare of some of the engineers that try to develop our technologies today, is when you think about the motor homunculus, and which really represents that amount of cranial or cerebral real estate dedicated to the function of the hand, the motor functions of the hand. And you look at how big those hands are. There's a lot more real estate dedicated to the hand function than there is lower limb function. So when you think of the daunting task that the engineers have to come by, you start to really understand why our technology is where it is and why it progresses a little bit slower. And with the media influence, a lot of people think that we should have been here. We should have been merging man and machine a lot earlier than what we're trying to do now. So as I've practiced over the years, I've considered myself almost a primary upper limb specialist since about 1997. There's principles, or what I like to call axioms, that I've learned that I kind of figure out and relearn as time goes on. They've kind of very influential factors. And I think Hep said it best: with the degree at which the prosthesis fits will make all the difference to the patient. And that's why we're going to dedicate a lot of time this afternoon to transradial, transhumeral, and shoulder fittings. And these speakers have kind of put together some really great programs to help impart that wisdom, because we do want you to go home and be successful, because we all need to be successful in the treatment of this patient base. So I'd like to introduce you to Joe and Carol. These are actually my first 2 upper limb patients I treated fresh out of my residency. And one of the most important lessons that I think I learned was not to necessarily apply just what I learned from school to a particular patient. And what I mean by that is Joe was this single guy. He works at a physical plant, does a lot of maintenance, working on machines for the city. And when I met him, I automatically thought, okay, this is a guy who's working with his hands. He needs function. We're either thinking electronics with a greifer. At that time I wasn't familiar with the ETD as much, or a conventional prosthesis. That's obviously what he's going to need. And then for Carol here, as a mother, a grandmother, active in her social groups and her church groups, I really think that she's going to want something more cosmetic. And so I immediately, within a couple minutes of meeting these people, kind of said, okay, this is what they're gonna have. This is what they need, and kind of didn't necessarily give them the choice. Just said, I think this is best for you. Let's go down this road. And what I learned, they did very well. She liked her cosmetic hand. He was very efficient with his greifer. But it was 4 or 5 months later, as we're following up, as I'm spending more time talking to them, that I learned that that really wasn't what they wanted. My hands-on tough guy, so to speak, he actually really wanted just an aesthetic prosthesis. He was a model wearer of a Greifer, great wearer of a Greifer, but here he is, talking to the artist as they paint his hand, because that was what was really most important to him, were those looks. And for her, for Carol, she was involved in her church, but she also gardened, she crocheted, and the best actual prosthesis for her was actually a conventional prosthesis with a 5XA hook. And she did very well, but what I want to impart on you is, it's important to really understand what is important for your patients and what they're doing. Now, we have an abundance of literature that kind of tells us what's important or tells us where we need to improve. And one of those areas is socket interface, which you'll hear a lot of different perspectives on that in the afternoon. And that really has to be probably one of the number one reasons people abandon their prosthesis. Unlike the lower limb where you really need a prosthesis to walk, for the upper limb, especially the unilateral amputee, they may just decide not to wear a prosthesis. And why that concerns us is, for me in particular, is I feel that that's going to lead to possible overuse syndrome of their sound side, or at least some kind of bad ergonomics. And I want those patients to be functional well into their long life. Because these upper limb patients, unlike lower limb, they're otherwise healthy besides this trauma that they had. These guys range from anywhere between 20 to 40 years old when they have this amputation. They have a long time to be functional. And so we want them to be as healthy as we possibly can. Now, I think Bittis goes on to really kind of give us our marching orders. That I consider these are the top 10, almost 10 commandments that we have to pay attention to if we want to really improve prosthetic care. And so I want you to really take note of this. So what she had found was, the people who rejected their prosthesis had some very, not just significant, but very significant results in these 10 particular categories. One, the fitting of the prosthesis, could range from comfort or so of the prosthesis, and then the follow-up on that prosthesis. Common complaints were lack of follow-up, lack of adjustments to repair. Right up there is training to use the prosthesis, as a very important aspect. And you look at information that's provided, especially the use of multiple prosthesis. It's very important. And down at the bottom, you have the overall knowledge and experience of the healthcare provider. In other words, our ability to go in there and really educate the patient and instill that confidence, and to some point involve them in that process of fitting their prosthesis. And most importantly, or actually everything's almost most importantly in my list here, but for this, if the prosthesis doesn't fulfill, the person's needs, it's not going to be worn. And this is something, just maybe about 6 months ago, this kind of blew me away. I had a kind of a second evaluation on a patient. He had moved here from somewhere else, and he was needing a prosthetist. And I knew that he'd been fit recently, and he was wearing conventional prosthesis. So we walked in, he was wearing his prosthesis, and so we were like, okay, go ahead and fill out your paperwork, and we'll be in there shortly. And then when I walked in, he was still filling out his paperwork, but he had elected to take off his prosthesis and utilize his residual limbs. And it just kind of was like, well, why aren't you using your prosthesis? And it came to find out that, with the exception of driving, he didn't use his prosthesis for much else, which, from a bilateral standpoint, I don't run into too many bilateral patients, especially nice, long, bilateral transradial level limbs that are almost perfect, why they don't wear a prosthesis. And when it came down to it, and I just questioned him more, he was just said, well, this is what you're going to have. You're going to have a conventional prosthesis to start, and you're going to have a hook on one side and a hand on the other. And it boiled down to that cosmetics were very important to him. He wanted a conventional prosthesis, but you know what? He just didn't like the cables. He didn't like the way it looked, so he just got used to not wearing them when he's in most public situations. He felt more comfortable, without his prosthesis. And the really, in this age of reimbursement and the talk about, these prostheses are so expensive. Well, the most expensive prosthesis, whether it be body-powered or passive prosthesis or electric prosthesis, that most expensive prosthesis is the one that's left in the closet, no matter what type that it is. And for this individual, what I ultimately recommended was, why don't we use, an Ottobock conventional hand where I can route the cable through the middle of the prosthesis. And I can route the cable and you don't see it, and it just comes out just above the elbow. And you just have a figure of 9 or have a modified harness for you. And that was something that he was very receptive to. Oh, I can get rid of all this and I can have a nice glove that goes up. And he wasn't as concerned with the fact that the hand might not be as functional as a hook, but it gave him that aesthetics. And for him, that was something that he could get behind a lot more. I've learned to really engage the patient in the process. The patient wants to feel a part of it and have some control, not to lead them. And one of the best ways I've found to do that is include them on either the cosmetic aspects of their prosthesis, or in this case, the graphics that are being detailed on this gentleman's prosthesis. We've frequently used this motorcycle shop that we have down the street from our practice that has been on Discovery Channel and a couple of the other channels, which is a very unique group of individuals that work there. The only thing that is more detailed than the bikes that leave there is their own skin, just entirely covered. But one thing that they've really gotten into is taking a person's prosthesis and reapplying those tattoos that they once had on their limb. And if you notice, the artist is looking at pictures of this patient's tattoo that's up here on his upper arm, and thinking about how he's going to make that tattoo kind of translate down to the lower part. And while this patient, I think, would have been a good wearer of a prosthesis anyway, he'd worn a prosthesis for 20, 30 years, this just made it that much better for him. And just very happy. Now, one thing I want to encourage everybody to do is give those patients that choice. I think you've heard that, over the last couple slides. And part of that choice is for them to understand that there are multiple prosthetic options that can be elected for. That no one prosthetic option is the most perfect one, and many times multiple prosthetic options need to come into play. And what I find is a lot of times the functional aspect of a prosthesis is definitely augmented by finding maybe what that activity was that they need to get back to. And for this gentleman, it's a bilateral patient, a partial hand and a styloid level. It was actually to get back and fish, because he was having a hard time dealing with his amputation, because he goes out and he fishes to relax, to kind of clear his mind. And he hadn't been able to do that since his amputation. He had tried, his friends had kind of taped on his fishing rod, and he was more confined than he was interacting with his environment. And an article I'd like you to take note of, and that's why I kind of put that in green, is this article by Sultan, DeBees, and Beasley about passive hand prosthetics in a hand clinic. It's been out for 9, 10 years. And this is the one article that I've found by a really credible group that with a massive experience that comes out and says, one prosthesis does not cover all the bases. And they go through the effort, a small part of the article, but they go through the effort to tell you why. And that's where the thought of axioms originally came to my mind, is because they list off this whole group of axioms that they feel are important for the hand level amputation. And expanding beyond that concept of function, or beyond prehensile type activities as that thought of function, and that passive prostheses are functional devices and kind of lend great credibility to helping that individual feel accepted in society. And they, front and center in their article, they show this particular patient, without any type of management, to his kind of passive, more kind of opposition post that's built for him, and his more cosmetic hand on the right that serves many purposes. Trial and preparatory fittings have really been something that's been very important to my practice. I think probably the first, if not second thing I was told and indoctrinated in my residency with Terry Supan was that you have to do a preparatory prosthesis. And this gives us the opportunity to validate design concepts, and it opens the door for simulations and assessment, not to simply do a test socket, make it definitive, and be done with it. A recent case I took care of, this gentleman on the right who's from Mississippi. And unlike up here, it's pretty hot down in the south. And many of my patients have difficulty with sweating, perspiration. Upper limb amputees already have that perception of greater heat than people who don't have an amputation. And so the preparatory prosthesis allowed me to kind of go through the thought, basing principles off what's considered an ergonomic socket design, or the Wilmer open socket, to develop a prosthesis that had a large open window right there just below the cubital fold, and reminiscent of the 3/4 socket with a large opening on the back. And it took something, it made a great increase, or made a great difference for him, because before he could wear his prosthesis for just about 2 hours before he had to take it off and dry his limb, because his electrodes would just not be functioning correctly. He was perspiring that much. And we tried a whole litany of different antiperspirants. And so he went up to 5 hours that he could wear his prosthesis without this perspiration causing an issue. And we felt that was a great success. We're still looking at the dynamics of how much can we cut away and still stabilize it, because he's a hard and fast user of a prosthesis. We have to have some biomechanics still in check with that prosthesis. And then the trial fitting, which Joe's going to spend a great amount of time on later this morning, it provides us the opportunity to assess the feasibility of multiple prosthetic options. Not one option covers the bases. Even with our more dexterous hands, we still are just a very far cry from being able to offer the patient the function, of their pre-amputation lifestyle. So many times, if you're going to go build a house, you just don't bring one tool, you don't bring one hammer, you bring that whole toolbox with you. So multiple prostheses act as that entire toolbox that you need. One of the common things I learned in my residency, and I still use today, is when maybe we're on the fence or we just want to allow the patient to try it out, is to use the kind of quick disconnect 1/2x20 adapters. They're both available by Autobach and Texas Assistive Devices. It's pictured there in the middle. It allows that prosthesis, the patient goes into therapy, to be an electronic prosthesis, a passive prosthesis, and an activity-specific prosthesis. And it gives them the ability to really try that through therapy. Some patients have elected for one, versus the other two, while many of them have really noted that I need all these particular options, and like the convenience of just being able to disconnect something off the end of their prosthesis versus getting an entire prosthesis to put back on. And multiple prostheses are important. This guy over here on the right, the same gentleman that you saw earlier in the earlier slide, one thing that was important to him, he never learned how to play guitar, but he just had a fascination with learning how to play the steel guitar. And so we devised something that would hold that slide for him on the end of his residual limb. And he went back, he went to the music store, and it got the interest of several, more professional players that have begun to give him lessons. So this activity prosthesis has, probably transformed his life more than any of the myoelectric prosthesis he's used over the last 10 to 12 years he's been an amputee. And things as simple as a shower prosthesis, an auxiliary prosthesis that someone will wear who's a bilateral amputee. And many times my bilateral patients will be like, "Oh, I don't need it. I got my ritual, down." But this patient was one that's been an amputee for 50 years, and he's like, "I've just never really been able to, just really get clean, clean my feet, do this." And as a result, he's had these recurring foot infections and things like that. And so he just kind of mentioned it one day while we were treating him. I said, "Well, why don't we just, duplicate your socket and make something for you?" And lo and behold, in about 3 days, the issues with his feet kind of went away. He was able to take that prosthesis home, and he came up. We had all these, creative loofah sponges and this quick disconnect mechanism from TAD and all these things he could use. And what he taught me most is, give me a hook on the end of it. Here's my towel. Sew it inside out. Make it like a glove, so I can grab onto that towel on the inside, and that's what I need to scrub with. And let's make it long so I can use my whole arm to clean. And his family was like, he's never been in the shower that long. He just goes at it. Another thing I learned is, myo is not always the answer. Many times as a specialist, we run to the most advanced technology as we can. For this individual, I admit I was thinking myo. He's a guy who had a different person than the one we saw before. He's wearing his prosthesis for 40 or so years. Good user of a bilateral conventional level prosthetics. But over that time period, his shoulders were becoming injured. He had rotator cuff injuries. He had neck injuries. And it was from using that conventional prosthesis for so long. And I see that after a long period of time. And, he had tried to go get surgery, and they said, with the pacemaker that you have in and the other issues that are going on, you're 70 years old, we don't want to touch you. We don't want to go in and have surgery. And so we think long and hard, and we had that talk of, if your wife can spend about 1 minute in the morning helping you with something, maybe we can devise something that will work. And I frequently would use an Under Armour shirt for a unilateral amputee with a rapid buckle or some type of quick release buckle that they just reach back and connect their cable onto. But in this case, I kind of broke from my tradition and did it on a bilateral amputee, where you see the orientation on the posterior aspect and kind of the incorporation of these suspenders into to the front aspect, that when he tucked his shirt in, it held the shirt down, the elastic shirt down, and turned the entire elastic shirt into one big shoulder saddle that supported his prosthesis. Then, of course, we had to get rid of the suspension component of the anterior straps from the traditional harnessing that he was wearing, and went more to a anatomical fitting. And he had this further challenge of 40 years ago when he lost his residual limb, or lost his limbs. He had all this shrapnel in his arms. And so this is why you see maybe what is a quite different type of socket design. It certainly wasn't where I started, but depending on the range of motion that he went through, the shrapnel that was scarred in would occlude his blood flow. So he would start swelling in different regions depending on what level he was flexed at. And so he went through several years of, I'm just fluctuating, and they gave him all this medication, and we just stumbled upon it because he was just sitting there one day as he's watching TV in the patient room, and he's like, my prostheses are getting tight. I'm like, well, why? And so we started taking measurements at different levels and realized that for some reason he was swelling. And then when we opened up those sockets, that helped. Now, while myo's not always the answer, I've learned that body powered is not the only answer. This was a patient that presented to us who wanted a body powered prosthesis. For all intents and purposes, we thought he was more of an elbow disarticulation amputee. Until we're just kind of feeling on the end of it and just realizing it's just doesn't quite feel the same. He's a dental student who was involved in a car accident, coming home real late from dental exams the last semester. And I have some good friends that are involved in medical modeling and 3D imaging. And something that's been used with a lot of the Walter Reed patients is getting that CAT scan, that MRI of their residual limb, and taking a look a little bit deeper than that skin surface that we're so used to working. And lo and behold, after his doctor took a look and the radiologist took a look, he has this heterotopic ossification presentation on the end. And that's not necessarily the presentation that you want to be powering into a body-powered prosthesis with, especially with all the points and the not so smooth edges that it has distally. So most importantly, set your patient up for success. When I get that call and the doctor asks, well, what should we do? What level of amputation? I've come to these same things that I harp on. The first thing is durable native skin, durable native tissue over that residual limb. The person on the right here, that's how they presented to me, a month or so after their amputation. The surgeons were, really happy with the graft they did. It had taken, it was not compromised. But I was like, I can't really bear any surface on that, any pressure on that radius, with it looking like that. And we were like, well, why don't you just kind of pull that tissue? You had plenty of tissue. I said, why don't we just get rid of that graft and pull it all around? And then that's what they did, and that's what we're looking at. They just felt, well, they can't really pull that tissue. They want to save all the length they possibly can. Myodesis is definitely the preferred method of muscle fixation, and allowing for a sufficient, soft tissue envelope. You never want that patient to come in and have blanching at rest, where on the end of their residual limb, it's that kind of white look like your knuckles, because that's an area that doesn't have really great blood flow. And no matter what prosthetic option they're using, that's going to become a problem. And then that thought that we need to progress is amputation is a functional restoration. Many times those surgeons kind of do some surgical acrobatics, really trying to help because they, in their heart, want that patient to have a good residual limb, a good functional outcome, and length seems to kind of go into that. I educate the different referral sources of physicians on traumatic stress. Not that I consider myself an expert at it, but I consider that they all need to be evaluated for that. Because, remember back, most of those individuals are traumatic amputees, okay? They were most likely awake during that amputation. They saw what was going on. And there's a lot to deal with there. We're not experts at that. And if we don't recognize that, it has an effect on our prosthetic outcome. It's even been said that, patients who really display a dissatisfaction with their prosthesis, they're having a hard time coping with their amputation, coping with the fact that they have a prosthesis. And I think I've seen better results with patients, not to take away from occupational therapy, but I've seen some of the biggest gains when those patients have gone into some form of counseling. And it's a difficult topic to broach with your patients. Most of them don't want to be talking about that, want to kind of put that behind them. And something I feel very strong about is therapy as an important component before, during, and after your prosthetic rehabilitation. Therapists are experts at preparing the residual limb and kind of breaking down those tasks, and we have to use those therapists routinely. And one of the most routine things that happens on my conventional wearers is that over time, like this gentleman down here on the right, those pecs have just gotten tighter and tighter and tighter from just the control motions that he uses. And my therapist, pictured up there at the left, Margaret Wise, will simply just say, I need to stretch this out. I need myself 3 to 4 weeks. You go away now. We'll get back to you when he's ready. Because these patients will show up and be like, I just can't really activate my prosthesis like I used to. Having a hard time. My cable must be worn. I must be having a lot of friction. Everything but, because they can't look above themselves and look down. They don't see that their shoulders slowly kind of come more forward. And therapists, is one valuable aspect. And setting that patient up for success involves that, just like Calais had said earlier, really early response to care, getting them fit quicker. Now, thankfully, I think the window of fitting is a little bit larger than what we all consider Malone's, that magic 30 days. It seems now with further research that window for our acquired traumatic amputees is more like about 6 months after their amputation is that golden time to fit. So in our field, we see some paradigm shifts coming, some that we welcome and some that we don't. And Harold Sears of Motion Control has a great quote that he definitely claims is not his, but I've never been able to find out who actually said it, is that when measurement replaces estimation, calculation replaces speculation. We're a group of estimators and speculators, and I'd like to see us move a little bit towards that other side. Now, Laura will be speaking extensively on outcomes. And, there was a time when we said, we really need to be looking at outcomes. We really need to be thinking about what our patients are doing. But, that time is pretty much now as the increasing scrutiny that comes on us from our reimbursement agencies. We have to show positive outcomes. And that's one of the battle cries of the society. We can't really afford to have any patient not do well with their prosthesis. A prosthesis that goes in the closet doesn't affect just that patient. It's going to affect all of us. And improving our outcomes is really everyone's responsibility. It's not just the prosthetists. And I really have to applaud Touch Bionics, who, for the most part, was really the first to come out with a really extensive training manual, on their hand. And they've come out, with really, dedicated outcome efforts to help track how their patients are doing. And, Ottobock has always been a good supporter of that. And I applaud Ottobock for coming out with, first thing out of the gate. They had a therapy, how to train someone with a Michelangelo hand. And, I wish that would be the case with other manufacturers, because I think that's a necessary component. I'd almost say that component can't come out until it has that training manual, all that information. So we're seeing the gold standard of our prosthetic hands changing. We've, for a long time, 30 to 40 years, it was a single motor, single grasp type of hand. And that's really given way to the multi-motor, multi-grasp hands that we see in the commercially available hands from the Bionic and the iLem to the Michelangelo. material science is going to be a big shift for us. Jackie Lindahl wrote a great introductory article about custom silicone for myoelectric prosthesis. And it's this concept of HTV, this high temperature vulcanized, high density silicone rubber that I think is going to transform some of the things that we do in upper limb prosthetics. This material, unlike some of the silicones we're used to in the field that are more injection molded, that cure at room temperature, this is a material that is much like the gel, the fitting gel that you would use for a distal end. It's very dense type of clay that you mill through, you work through a two-roll mill, and you almost form it on the model as if you were seaming a piece of plastic as you were doing that type. You roll it out. There's a lot of, it's hard. There's a lot of things that go with it. There's a lot of things that have to be together, some like magic, from anywhere from humidity level to temperature level in your room that can just rear its ugly head. But the result is a prosthesis that you can just infinitely adjust, from what durometer do you want, to the strength, to the stretch. And that type of adjustment is what we need for our upper limb patients. Now, Chris had showed a slide earlier about, highlighting battery technology. And, we haven't had just a really great change in battery technology in a while. And what I think is going to really come to play, and what my patients are liking, is these gel polymer batteries from Infinite Biomedical. And what they allow us to do is get rid of the lump. Patients, want that prosthesis to be as smooth as they can. They want to be able to button their shirt easily, around the end of their prosthesis. And so what these batteries allow us to do is to just really flex them around the residual limb. It allows us to customize the amount of power that a patient needs. And as our terminal device technology increases, our battery, our power demand is going to definitely increase. And probably what will be the biggest change, both in our thought and our practices, will be the partial hand population. When we talked about those numbers earlier and we broke them down, you saw that 18,000 number. It went all the way down to about a 2,000 number. There's 16,000 or so amputees every year that have an amputation distal to their wrist. And while some of those may be fingertips, a large portion of those are partial hand level amputees. And for the most part, we didn't have a lot of options for those individuals beyond a passive prosthesis. Now with the electronic options that are available from Touch Bionics, the forthcoming options from a company called Vincent Systems out of Germany, as well as the M-Finger components made locally in the U.S. for body-powered applications, really gives us a better choice for these patients. But there's some definite challenges with the partial hand level. There's a vast surgical presentation. And the traumatic nature of their residual limb it leads to these real complicated biomechanics. Life was easy when you had to think about 7 1/4, 8 1/4, what color glove. But when you got down to how you're going to fit around this residual limb, not stop the thumb from having any more range of motion, and how are you not going to create this heavy prosthesis or this prosthesis that is hot? It's very, very, very difficult. And the emerging digit options, it's, the cutting edge is the bleeding edge. And there's a lot of learning as we do this. They don't have the benefit of 30 to 40 years of hand technology to rely on. This is new, uncharted territory. But what's so fun about this opportunity that we have is a chance to really kind of formulate our clinical protocols, our research. It's a ground-up type of thing. It's not us, retrospectively trying to rationalize what we're doing. It's here we are now. We've got outcome measures that we can use. We have some sound clinical direction that we can go. Let's apply all that and study this group from the beginning. But the caution is how we have to treat this, this type of individual. It doesn't really have a foundation in what we've normally done. We consider ourselves pretty progressive specialists, but it's very new territory. And the challenge is every patient presents differently. And so it's almost like relearning how to fit a level over again and over again and over again till we amass that amount of experience that we need. Now, those are all kind of changes that are happening to us. There's a change that we have to make happen. And the society feels very certain about this. is we have to help progress the concept of amputation surgery and the restoration aspect, getting back to that being a functional type of procedure, not just a save everything that you can. Our challenge is decades of surgeons that have been, raised on a couple specific thoughts. And, I include this in another a quote that, I don't hear as much, but I still hear. And it's the thought that any salvage of a workable sensory part of the hand is, far more worthwhile, far better than what any prosthesis can provide. And that's a myth, and we have to be myth busters, and we have to stamp that debunk right on that statement. But our challenges are great because there are articles that have come out that look at salvaged hands versus having an amputation and going ahead and having a prosthesis, and those results look at saying 50% of those cases of salvage, even though that hand is impaired, have good and excellent results, whereas none of the prosthetic management had what they considered a good or excellent result. But when you dig deeper, you find out that the outcome measure that they use, this is why outcomes become very important, the outcome measure they used looked at very dexterous type of items, okay, very, very hard task, that you have to have independent finger movement to do. Well, when that study was done, what do we have? We had a sensor hand, and that's what I think the majority of those patients were wearing. Very effective, but they couldn't complete certain tasks, therefore were kind of relegated to this not so good outcome. And funny enough, unfortunately, not in the front of the article or in the abstract or anywhere in the introduction, but way down there in the summary, they said, oh, by the way, we removed all the things that were considered dexterous tasks, and the prosthetic hands performed just as well as the salvaged hands. But unfortunately, that's not what's quoted. So how do you apply this to your practice in doing upper limb prosthetics? At the heart of it, it requires a time commitment. A preparatory fitting is a long-term evaluation of that patient's function. It's not just a test socket. You have to attend therapy sessions. I try as a goal just to attend one a week of my patients. And this is just a screenshot I took of a patient wearing a Michelangelo hand. So why was it important that I was there and I was watching him do things? They were working on co-contracting. He was a stud, long, short. He could do whatever he wanted. But I just had this resting signal down there. I'm like, okay, I turned down the electrode. Resting signal's still there. And I realized, one of the things that, catches me a lot is I kind of cram a lot of wires up in there. And I had crammed everything up there, battery, processor, wires. And it didn't look so good as I started pulling it out. So I created this problem that the therapist was actually having some difficulty, with his training. And so you pick up on things because it just doesn't happen in your office. They open, they close, they do different things. And if you don't have a therapist taking them through the routine, you don't notice all of these things. And these patients go a while with this. You have to make adjustments quickly and often. You have to change that socket, routinely through the process. And this is a particular technique that I first learned in Illinois during my residency and really honed in on it. Is the fact of taking your socket, your test socket, putting it back on your mold, shaving off what you need to reduce, and just reforming that socket, just pulling a thick metal plastic bag over it and re-vacuum forming that same socket and going very quickly through the process with that patient, making socket changes. And the time commitment also comes down to reading and researching and refining your techniques. I always find it funny that some of the new ideas that we consider, new modern socket design, 1969, this is when the thought of doing a transhumeral level socket where it's open and looks more modern came about. And that's a while ago. But, going back to that research periodically just to refresh your mind. And you remember that gentleman that I had from Mississippi that had all these heat problems? Well, I had another one from Louisiana. He's been a patient of mine for about 12 years, and he always had this kind of contact dermatitis heat rash issue with his prosthesis. Strong Utah wearer. He's like, man, if we could just cool this thing down. And I just thought to myself, I'll put something in there to chill it. We were going this whole cool technology way. And I thought, I just wonder if I just cut this out. And I just remembered something that I had seen, a while back ago. And lo and behold, McLaren Solder, who's credited with the more open socket designs, just had in the article as a footnote. It said really the only two parts you need is this axillary yoke up around, to get your deltoid pectoral groove, your stability, and this distal ring. Everything else, you really don't need it. And I was like, well, that's interesting. But, he says, you just need everything else for structural integrity. Because maybe in the 60s, they were limited in, some of the materials that they could use. So they needed that to hold everything together. And I was thinking to myself, I don't know if I need all that necessarily to hold everything together. And this is after a week long of fitting with them. Now this design has refined itself a lot. We've done this back and forth in the mail, and we've Skyped, and I've done different changes with them. But essentially, I just open that up. You see the lateral aspect, the anterior posterior aspects, and then what I think made the biggest change I did is I opened up what's distal or inferior to the axilla, and his statement was I no longer feel heat issues at all. And we did this at the beginning of the summer in Louisiana. It's hot and sticky, where he's from, and his issues went away. And what's even more important is what we thought was just a heat issue came right down to around the electrodes. He still had the same contact dermatitis and the rash around the electrodes. And it's like, oh, maybe you're allergic to the metal. Went to the dermatologist. Oh, you're allergic to the metal of these electrodes. So Harold Sears supplied some gold electrode contacts for his, and all of a sudden, it doesn't appear that exists anymore. That heat made the whole rash encompass the limb. So I encourage you to read and research and then refine your techniques to see what you can do for the patients. And you have to always investigate new techniques. These are some interesting concepts that are coming our way, from Jay Martin's more almost all fabric-based type of suspension and support of a prosthesis on the left to David Latour's Anchor, which eliminates the harnessing, the axilla compression that many of the body-powered users find discomfort with, to Randy Alley's concepts of his high fidelity, or that alternating compression and relief to try to really grab that residual limb, that bone, to enhance their range of motion and their ability to actively use a prosthesis. Now, Chris had kind of talked about this earlier, and the Upper Limb Society, which I've been fortunate to be a part of, and have just a great group of individuals that are just very dedicated at work with me. We're on a mission. We realize that 3, 5%, 8% or so of a normal practice is upper limb, or that makes up the population. Well, that 8% or so, you still have to know 100% of that information, and that information is changing. And as I think about our state of practice, it's somewhat fragmented. I mean, we have to look at ourselves and know that progressive upper limb prosthetics tends to happen in isolated areas. Okay, it happens up at RIC. It might happen over the Mayo Clinic with Pat Prigge. It may happen down in Texas. It may happen across the hangar groups in individual places with specialists. But it's not a global thing. There's not a global resource. There's not a pathway, if you will, to really kind of set the bar and to go to and to add to that information. And Carl Brenner, one of the original members of the society, admits, the realization that upper limb fitting and care requires, special expertise on the part of the prosthetist and therapist, and that will result in improved care for all. That's in the 90s, and that's really now too. So we have to kind of raise that level, but give people the ability to have that specialist aspect. And so a couple years ago, and it's in flux at this moment, is we developed this roadmap. Mark Mueller, who was the past president of the Academy, as he looks at the education changing for the students, realizes this increased need to have people be able to pick specialization tracks. I mean, in our field, we have kind of done that. We have people who almost primarily do cranial molding helmets. We have people who almost entirely focus on orthotic needs of children, and even a larger group that's looking at vacuum and looking at sport type of prosthesis. We need to provide the ability, the paths for those individuals to gain more knowledge and to share that information, so that we don't recreate what we're doing on a normal basis. We refine what we're doing, and our field keeps growing and moving forward. And so we developed this roadmap, this concept of a specialist, looking at the education opportunities and how it was available to all prosthetists and students. Developed the core concepts to look at. The Academy webinar series, came about from that need for us to want to be able to get a presentation out there and quickly get it up to the online learning center. And so one of the couple first webinars were upper limb based because we had really tried to push that topic. And this certificate module is that first module of many that we hope that will encompass the upper limb specialist area. So for future reference, these are the places, these are the books that I would advise everyone to have on their shelf. The Powered Upper Limb Prosthetic book that came out of Canada, Diane Atkins' book. There's multiple publications, multiple Academy publications that the Society has contributed to, from socket design to evidence-based medicine to overuse, and especially the care of the combat amputee, because that is a very unique group of individuals and just real, up-to-date information on what we're doing. And of course, all these particular three manufacturers who do a great job of over the years have just collected a vast amount of information. And then finally, there's two triennial conferences that run: the University of New Brunswick Conference and the Trent Conference. It's over in the UK. Those are a 3 to 4 day, entirely dedicated to upper limb topics type of conference. I'd like to acknowledge the Academy for putting on this seminar and their willingness to take on the aspect of increasing the specialist education of everyone. Chris Robinson, our co-chair, who bravely kind of took on this topic and is kind of part of that task force to bring specialists to life. I deeply appreciate my society board, who just give and give and give. It's a kind of a volunteer army type of thing. And the volunteer army is hard. You're on duty between about 1 and 3 o'clock in the morning, kind of like when you have kids. And then the fellow speakers, which, just the high caliber of speakers that we have here today. And I've had a chance to kind of glimpse at their presentations. And you're going to hear about the state of the practice, the bar to go to. You're going to hear about that over the next 7 to 8 hours. So I thank you for your attention this morning, and look forward to a great informative day and interactions with all of y'all.